Let's discuss about ARNI, which is Angiotensin Receptor-Neprilysin inhibitor. It is a combination of sacubitril, which is neprilysin inhibitor, and valsartan, which is ARB. The mechanism of heart failure and role of ARNI. These two systems work in antagonizing fashion. Renin-angiotensin-aldosterone system (RAS), which worsen the heart failure if overactive by increasing sympathetic activity, vasoconstriction, sodium retention, increasing blood pressure, and promote maladaptive cardiac remodeling. The natriuretic peptide system antagonizes RAS with the help of ANP and BNP. It counteracts the heart failure effects by decreasing sympathetic activity, vasodilation, natriuresis, diuresis, decreasing blood pressure, and protects against remodeling. ACE inhibitors and ARVs such as valsartan, they blocks the RAS and prevents the worsening of heart failure. Meanwhile, natriuretic peptides are degraded by neprilysin. So, neprilysin inhibitors such as sacubitril prevents the breakdown of natriuretic peptides and help in counteracting the heart failure effect. So these two drugs are combined for the treatment of heart failure. Now, inhibiting neprilysin will lead to the accumulation of angiotensin 2 and bradykinin. So a neprilysin inhibitor should be combined with ARV to block the effect of excessive angiotensin 2, and it must not be combined with ACE inhibitor due to increased risk of angioedema due to increased bradykinin levels. 36 hours washout is required when switching from ACE inhibitors to ARNI. Now the indications for ARNI, heart failure with reduced ejection fraction in NYHA class 2, 3 and 4 patients. It is included in 2016 ACC guidelines. They are used instead of ACE inhibitor or ARVs. Heart failure with preserved ejection fraction included in 2022 AHA guidelines. Pediatric patient with heart failure, cancer therapy related cardiac dysfunction, there is limited data but emerging treatment option. Adverse effects include hypotension, hyperkalemia, renal failure, cough and angioedema. The incidence of hypotension is more frequent as compared to enalapril, while hyperkalemia, renal failure, and cough are less frequent. Angioedema is slightly more frequent but statistically insignificant. The dosing of ARNI depending on the patient group. When the patient is not on ACE inhibitor or ARV or on low dose, the patient to be started on 50 mg BD. If the patient is already on moderate to high dose of ACE inhibitor or ARV, then we start 100 mg BD after 36 hour washout period. If there is a renal impairment of eGFR less than 30, we start 50 BD. Hepatic impairment with child pug B, we start 50 BD. The dose to be up titrated, we double the dose every 2 to 4 weeks as tolerated. ARNI can be given with or without food. The contraindications for ARNI include severe hepatic impairment of child pug C, pregnancy, breastfeeding, patient with prior history of ACE inhibitor or ARV related angioedema, hypersensitivity to any kind of drug component, and diabetic patient taking L-carnitine, which is renin inhibitor, due to increased risk of angioedema.